All right. Well, thank you very much. I appreciate the opportunity to be able to share with you guys today. Tell you a little bit about me, just the credentials, so you can see that I'm not just some strange random guy up here talking. I am a licensed marriage and family therapist. I have been a licensed marriage and family therapist since 2014. I've been with One-Eighty Counselling from the beginning. Whenever I first started at One-Eighty Counselling, there were all four of us. We now have 6 offices and over 100 therapists, so we have grown tremendously. My role within the practice is director of clinical development. I've always been very passionate about the teaching part, not just doing therapy. Being able to have opportunities such as this is kind of pretty exciting for me. I oversee a group of interns who have the book knowledge of what it means to be a therapist, but they don't have a whole lot of practical experience. That's where I step in. We have a cohort of about 7 students each semester across a lot of the different schools in the area, and to give them the kind of the training process so that they are ready once they graduate to do what we do. I am a supervisor, so if you are ever working with a therapist and they have a letter A at the end of a bunch of other initials, that means they are at the associate level. They have a supervisor such as myself, and we do case consulting and those sorts of things. I've created a lot of different training programs for relationship building stuff, supervision for all things therapy and whatnot. So again, I know and love the world of mental health, but I also love the world of the church. My previous life, before I was a therapist, I was actually on staff at a local church in the Garner area. And before that, I was on staff at a church in Florida. When it comes to the intersecting worlds of the church and mental health, that is right up my alley. It's probably, I think, a year ago, our church did a whole series on the mental health in the church. And that was exciting to be a part of that. My wife and I, we just started a ministry within the church, care ministry, and to offer coaching, mental health coaching for those who are struggling, maybe not quite sure or ready to step into the world of a professional. Maybe they don't quite need a professional yet. So it's kind of a great opportunity with that. So now, again, I am also a family man, so we can show the slide of my family because I love my family. Got my wife and I, we've been married for 23 years. It's coming, I promise. Almost. Skipped one. There they are. All right. So we've got my wife there. She's actually surrounded there in the middle. My wife and I, we've been married for 23 years. She herself is going to be starting at Liberty to pursue her degree in counseling as well in August. So our whole family is kind of in the mental health world. So I'm excited for her as she ventures into this arena as well. I used to joke between the two of us, she's the one who I think is more uniquely gifted naturally to be a therapist, not myself. And so she's just a little bit catching up with things. So that's my wife. Her name is Sarah. We've got 4 kids. My oldest, she is a junior at Liberty University in the nursing program. And she is studying her brains out and starting the clinicals this upcoming semester. So she's excited to get into the hospital setting. You've got my son, who they would have all been with us today, but he's not feeling well today. But he is a junior in high school. And then we've got my middle daughter, Addison. She's the one right in front of me. She is a rising 8th grader in middle school and plays competitive travel volleyball. We literally just finished the season, and I think we hit 5 or 6 different states all here in the South, playing a lot of volleyball. So I'm exhausted to rest up for this month because we start again in August. And then we've got my youngest, Avery. She is also an aspiring volleyball player, which makes me one of those crazy volleyball dads. She's in 5th grade, and she is finishing us up because we are done with kids after 4. So that is our family. But of course, you guys are here to hear a little bit more about mental health. So I want to start with sharing some of the basic different roles that we have of the mental health providers. Within the field of mental health, there are 3 primary roles or positions or titles that there are. There are many more, but these are the at a much broader global scale. The first is a psychologist. Now, a psychologist has a doctoral level training. They primarily focus on research and completing evaluations and testing. Typically, you're going to see a psychologist just for that single incident to kind of work through whatever testing evaluations. They can do full psychological evaluations. They can do ADHD testing evaluations. We have a psychologist on staff. His area of expertise is on bariatrics. So for someone who is going to get a bariatric surgery, obviously it's pretty life-altering. So he completes an evaluation assessment to make sure they're ready to go into this journey. So a psychologist primarily focuses on evaluation testing. Trust me, they do a lot more than that, but in a nutshell, that's one of their biggest roles and responsibilities they have. The second is the world of psychiatry. Now, the easiest way to think of what a psychiatrist does is you take your primary care physician or your doctor that you see for medical issues, and you blend it with the world of mental health, and there is the psychiatrist. They manage mostly, again, they do a lot more than this, but a lot of times we are referring our clients to see a psychiatrist for medication management. So if they're taking medication for some sort of mental health issues, struggling with anxiety or depression or a mood disorder, or any other number of things, they are primarily managing the medication side of things. If I've got a client who's taking multiple medications, I really encourage them to work with a psychiatrist because they can manage all those things and make sure the medications aren't tripping up on each other. My aunt, unfortunately, did not work as a psychiatrist, and that's probably the very thing that took her life because her medication was creating all sorts of mess, and there was no one single person to manage all of that. She had an individual doctor doing this, another individual doctor doing this, and probably need a psychiatrist to manage all the medications so they didn't trip up on them. So I do enjoy the psychiatrist and referral for psychiatrists. The last area that we're going to focus on primarily today is my role as a counselor and therapist. We are the worker bees. You are likely to see a psychologist, like I said, for the single moment to work through the evaluation or the testing. The psychiatrist, similar to your PCP, primary care provider, you're likely to see them to start to get the prescription, the medication, and then to just check in every so often just to make sure medication's working well. You're going to see your counselor or therapist, or sometimes you hear the word psychotherapist. You're going to see us a whole lot more than you will your psychologist or psychiatrist. So our primary role is to assess the current mental health concerns and to help you work through whatever issues and symptoms you've got going on. So let's talk a little bit about the purpose of therapy. Go ahead and change the slide for us. The purpose of therapy is to help you walk through your presenting mental health struggles, whatever that is. We are the experts, so to speak, of mental health. You are the expert of you. So our goal is to get to know a little bit more about your story and what's going on. And our job is to literally walk alongside of you in this journey, okay? When you go to see a doctor, for example, and you're sick, the doctor's going to give you a script or tell you to exercise or eat right and those sorts of things. They're often telling you what to do. That's what separates us from a doctor. We're not going to necessarily tell you what to do because you are the expert of what you're thinking, of what you're feeling. I don't know. I can look at your behaviors and tell you what's going on. I can look at the symptoms and understand about what's going on, but our job is to help you walk alongside of you to reduce some of those symptoms. So it's less of us telling you what to do and more of us kind of exploring it together. As I was talking to someone yesterday, they would rather have a broken arm and a broken leg than to have a mental health issue because these things, when it is pertaining to mental health, it is so difficult to work through because nobody sees it. You can see someone with a broken arm. You can see someone with a broken foot. We often have more compassion with someone who has a physical health issue. A lot of times we don't have as much passion for mental health because we don't understand it. And that's where the stigma comes in. There's a great stigma, unfortunately, with mental health and what it actually is. My belief is stigma typically comes because people simply don't understand. Luckily, there's less of a stigma on mental health in the world at large, thanks to many people of influence who have kind of come out with their own mental health journeys. But the one area the stigma still exists, maybe even stronger than the world at large, is within the church. And again, I get very passionate about that because I like the two to coexist, and most people just don't simply understand, but because, again, they can't see it. What we don't understand, we often jump to assumptions and judgments and those sorts of things, and it's a shame. We often hear, unfortunately, someone who's struggling with depression, get over it. Or we hear someone with who's struggling with anxiety, and you go and tell someone, oh, just calm down. I don't know about you, but never in the history of the universe have you been told to calm down and like, that's a brilliant idea. I think I shall do that. Right? It just doesn't happen. Mental health is very different that way because, again, we can't see it. We don't understand it. So that's why I was excited to be able to share with you and hopefully help you understand a little bit more about mental health, what it is, and how we can help. All right. Next slide is going to tell us a little bit more about therapy, kind of what to expect. Like I mentioned, the frequency, a psychiatrist, kind of a one and done. Sorry, psychologist, one and done. Psychiatrist, a few more times, maybe several times throughout the year, just to make sure everything's going okay. For us, the worker bees, you're going to see us a lot. To start with, it'll probably be once a week or every other week. It just kind of depends with the severity of what's going on and stuff. So you're going to see us a whole lot more often. So with that, the next point there you see is finding the right fit is really important. I would like my doctor to be nice, but if I'm got a doctor who's a specialist in a particular area, I'm okay if they're not super nice to me, as long as they know what they're doing. But if I've got to see someone every single week, I really want to make sure they're nice. And so we want to make sure it's a good fit. So part of what we're looking for, what I would encourage you guys to look for, or a friend or family or loved one who is looking for a therapist, to find someone who's a good fit, is someone that they can trust. Someone who has an area of expertise in whatever it is that they're struggling with. Someone who, I had a client one time, it wasn't obviously my client, it was a client of a family friend of mine, and they said they found a therapist because they looked at the picture and looked like their sweet grandmother. And that's the reason why they chose that individual, because they had a great relationship with their grandmother growing up, and they're like, I always felt safe around this type of person, so I want to work with someone similar to that. I've had clients who are working with me simply because I'm a guy, I'm a dude, and they are convinced, well, some couples see me because the guys are convinced I'm going to tell them their wife is wrong. Definitely not the case. Sometimes it's the other way around. So they often see a therapist for any number of reasons. That is primarily up to you, whether it's with their bio, different areas of expertise, and whatnot. Now, I don't have this on the slide, but let me kind of share this. If you have a pencil, you might want to write this down. There are a lot of different licensures within therapy. Just so you understand, I apologize in advance, the world of mental health, we love our alphabet soup. You will see letters behind our names. You will see a bunch of letters in our bio. And if you understand a little bit about what those letters mean, that might be helpful. So one of the more common ones we see is an LCSW, Licensed Clinical Social Worker. You see them a lot of times they're in the hospital settings, in a school setting. Primarily their level of education is on understanding mental health from a societal standpoint, and they are excellent at working with little cases. They probably got a large caseload, and their job primarily is to make sure their clients have the resources they need. That's primarily what a social worker does. Now, if they are a clinical social worker, they could do talk therapy such as myself. Again, their education is much more generalized and at a global macro level. Then the second most common is probably the LCMHC, or the licensed clinical mental health counselor. That is what I call the jack of all trades. They have a lot of training in just understanding diagnoses and symptoms, and they can work with almost anything and everything that comes in the room. Again, like I said, the jack of all trades. They've got a global understanding of mental health. Then you have subset specialties, such as myself. I am a licensed marriage and family therapist, so you can take a guess at what my area of expertise is on all things relationships. And so we understand relationships. We understand how people operate within systems or relationships, and we're convinced we are who we are, and we act how we act based on the relationships we are in. My own case, as an example, I grew up in a home where there's not a lot of talk about any emotion whatsoever. The one emotion that was okay was anger. And then my dad was pretty critical. So, of course, I find myself to be insecure. I'm always second guessing myself. It doesn't matter what accolades I've arrived to or achieved, I still second guess myself because I've become very insecure. And so you put that in the context of, thank you, of emotions and whatnot. You can have someone who's an avoider, such as myself. I don't like a lot of strong emotions. I typically run from conflict. Now you get in the hint of why I think my wife is better suited to be a therapist, not myself, but God and his sense of humor. Here I am. And so, again, that has created me and why and how I operate within the system. So licensed marriage and family therapists, such as myself, we have the expertise in the world of relationships. You also have an LCAS, that's licensed clinical addiction specialist. So if you've got a friend or family or loved one who's struggling with addictions, strongly recommend looking for someone with LCAS at the end of their name, someone who has a specialty in working with addictions. There are a lot of other certifications and trainings. We have got certified sex therapists. We also have EMDR certified therapists. There's a number of different types of certifications, but that is it in a nutshell. Like I said, we love our alphabet soup, so hopefully you understand a little bit about what those are. So that is, again, about finding the right fit, looking at the alphabet soup, reading their bio, look at their picture, see if you can get a sense of, is this person someone I feel I can trust? Because in therapy, you're going to share some very deep, dark secrets. There are many things that clients have told me that they have not shared with any other human being on this planet. And I'm the bearer of these secrets, so to speak. That's a heavy load to carry. So much more, this individual has to trust us. And if they don't, and if you're working with someone you don't trust, I'm going to encourage you, you might need to find someone else. It's okay to do that. You want to make sure that you find someone you trust. Research says that it's not so much of how smart we are or the different theories that we're going to look at a little bit later. The thing that indicates the most success in mental health is your relationship with your therapist. If you like them and you trust them and you're willing to open up and talk to them and with them, you're likely to see the most benefit and the most help out of that, no matter how great and smart we are. Which now makes me wonder, that was a lot of money to put behind some letters when all I got to do is be a nice guy. It's good to know and understand a lot of things, but it's also good to be just a nice person. So you want to make sure you find a really good fit. The session length. Now, this depends on the individual therapist, also depends on if you're using insurance. A lot of counselors and therapists, we do use insurance. Most insurances cover mental health, thank goodness, but not everybody does use insurance. If you're going to see someone with insurance, the length of your session is dependent upon what the insurance determines as is appropriate. So within the world of insurance, typically it's anywhere between 50 minutes to 53 minutes on average. For some reason, those of us who work with families, they give us less time with more people in the room. I'm still trying to figure that out. If it's just you in the room, typically it's 53 minutes. Now, if you're not using insurance and you private pay and you don't have to worry about the confines of the insurance world, typically they will go anywhere between 60 minutes to 90 minutes. Some will go all the way up to 2 hours. That's a long time to talk to someone. I know I'd be exhausted after 2 hours because I am exhausted after 2 hours. But in general, I would say the session or each session is going to be anywhere between 60 minutes to 90 minutes. More often than not, they're going to err on the side of an hour. And again, that's an hour a week or an hour every 2 weeks. And that's going to be determined upon you and the therapist and kind of what's going on. So that is the session length. Generally, you're probably going to work with your therapist for several months. However, it could be a bit longer. It just depends. I've got some couples I'm working with, working through affairs. That's going to take a little bit more than 3 months. Sometimes it could be multiple years. Sometimes they're what we call lifers, meaning I'm going to work with them to some level or another throughout their lifespan, not necessarily every single week. Generally, what we try to do is we'll start once a week or every other week, and then we'll begin to phase down from there based on how well you're doing. Once you're doing okay, sure, we'll phase it down. If you're doing weekly, you can go to every 2 weeks. If you're doing every 2 weeks, let's try once a month. If you're doing well in that, let's try every 6 weeks. For the brave souls out there and you're actually doing really well, we'll do a check-in once every couple of months just to make sure you're still doing well. Again, our job is to work with you alongside of you to make sure you are meeting your goals. So what to expect? Session 1 looks slightly different from all the other sessions because session 1, I don't know you, you don't know us. Most of the clients that come into our office, they've never done therapy. So they themselves don't know what to expect. Obviously, the first thing we go over is confidentiality. We want to make sure that you understand confidentiality and what that is, what it's not. As I like to tell my clients, whatever happens here stays here. Whatever we talk about in the confines of our therapy room will never, ever, ever go beyond that room for any reason whatsoever. Unless, here's the few exceptions, unless there's a concern if you hurt yourself, somebody else, or if there's a court order signed by a judge. We are going to protect your information to the nth degree. I will do everything I can to protect it. Some people are convinced, well, if I go see a therapist, they're going to give me a label or a diagnosis and my employer is going to find out, or the military is going to find out, or if you're in the police force, they're going to find out. No, they won't. I am the only bearer of your diagnosis, and nobody will have access to your notes unless I give them that access, that permission. And even that I cannot do unless you sign a release of information. And even then, I will only share the information you want to. So I've got some clients who are seeking therapy because work encouraged them, it was getting in the way of work. And the release is just saying, can you verify that I'm actually seeing you once a week or once every other week? And that is all I will give them. I will not give a diagnosis. I will not give the goals. I will not give anything unless the client gives me permission. Some people say, well, what if my doctor reaches out? Or what if a lawyer reaches out? I still will not share any of that information unless you as the client give us permission to do so. And even then, we will have to have a release on file. Just because a court asks for information does not mean I have to give it to them. Unless assigned by the judge, that I will have to give. Outside of that, your diagnosis, your goals, or anything we talk about will never, ever, ever go beyond the room. So whenever I'm talking about we protect your confidentiality, oh, we will absolutely protect it because my life and my license is on the line, and I'm not willing to risk that for anything. All right, so that is a little bit about what to expect. Our goal in that first session is to get to know a little bit more about you and your story and kind of what's going on. And so with that, it's more of the client doing the talking. We're asking a long list of different types of questions simply so we can get to know you and the story. What's going on? What are you experiencing relationally? What's going on? What difficulties is showing up? There's a big crossover between mental health and physical health. Sometimes people go to see the doctor because they feel like they're having a heart attack. Maybe they're not having a heart attack. Maybe it's a panic attack. And so then they refer them back to us for mental health. Or we're having GI issues and there's a lot of rumbly in our tumbly. as I like to say, that's the seat of anxiety. We feel emotions in our body. That's why a lot of people, they end up seeing their doctor for concerns when in reality, sometimes, not always, of course, sometimes it could be a mental health thing. I carry stress right here. I get those stress migraines. Oh my goodness, those are debilitating. Some people carry depression in their shoulders or in the back, especially guys. Anxiety, obviously, could be in your chest or in your gut. We carry emotions with us in our body. And so it is not uncommon for us to end up seeing a primary care physician who then will refer us to go see a mental health provider such as myself. So again, I'm asking all sorts of questions because I want to know all of these things about what's going on so that I can conceptualize or understand you and the struggles of what's going on and how best we as a therapist can serve you and meet those goals. Typically, either at the end of the first session or the second session is where we come up a list of goals, because we're not just in here mindlessly talking and shooting the breeze and just getting to know each other. Sure, that's part of it. But we actually want to be able to help you meet whatever goals you have established. So for me, I typically do that in the second session. So session 2, someone walks in, I say, hey, how's it going? Are there any other big updates? Kind of get any updates. Sometimes people leave the first session like, oh, I forgot to tell them I'm never sleeping well. Kind of important to tell me that. So they come back and said, I forgot to tell you, I've not slept in weeks, or I've lost 20 pounds in the last month, not because they're dieting, just because of all the stress. Like those are all things that we would need to be aware of. And so I take that, and then the second session, basically we shift to, okay, so what are some goals you'd like for us to work on during the time together? Because my goal, like I said before, is to walk alongside of my client to meet whatever goals they have established. Again, the client is the expert with their world. I can't tell them what they're thinking. I can't tell them what they're feeling. I can't even tell them what they should or shouldn't do. I've got some strong encouragements of what I think would be helpful and some things that I know would not be helpful, but I cannot and I will not enforce my obligations or morals or values or anything upon the client because they are the expertise. My goal is to walk with them through whatever issues they've got going on. So that's a little bit about what to expect. Sessions 2, 3, and beyond are all about doing the work. And talk therapy, you basically share and talk through things. We teach basic calming coping strategies. We talk about how to handle and manage anxiety. I'm a teacher at heart. I want my clients to understand why they do the things they do in the first place. We often cannot change things unless we first understand it. I like to give the illustration. Imagine I bring you into a room. I show you there's a bullseye over there. I give you a few darts, and I say, hit the bullseye. But first, I blindfold you, spin you around 10 times. Then I move the bullseye and say, go for it. What's your chances of hitting the bullseye? It's never going to happen. You might throw a lot of darts. I'm likely to get hit quicker than the bullseye. So what I'm trying to do is say, hey, that right there is called the bullseye. These are called darts. Let's get really close and let's see if you can hit the dart from there. And so my goal is to help you understand what it is that you're experiencing, why it is that it's existing relationally, maybe what's going on, what's contributing to the difficulties, and what are some things you are already doing that have been helpful and beneficial, and kind of build on that as well. So that's a little bit about what to expect in therapy. The next, I briefly touched on this before, is diagnosis and goals. We do not focus, most therapists, some do, most therapists do not focus a lot on diagnosis. We have a diagnosis if you're using insurance. Yes, we absolutely have a diagnosis if you're not using insurance. Some therapists don't crack open their DSM at all. I wouldn't go so far as to go to that level. But because of the stigma with that, what we don't want to do is give you a label that has a lot of negative connotation. And then you have to carry that around like a scarlet letter. And you walk around and said, yep, I've got manic. And people are like, oh my gosh, you got what? And they just don't understand it. And so I'm less about that. We focus more on the symptoms. What is it that you're struggling with? How can we help you? So we're less focused on diagnosis, although we have diagnoses, because that helps us to know how we can best treat you based on research. We often focus more on the symptoms. And so our goals, obviously, is let's reduce some of these symptoms of whatever it is that is going on. So that's diagnosis and goals. Last area on this particular slide is comorbidity. That's a fancy word for dual or two or more diagnoses. So these are the individuals that meet the criteria for multiple diagnoses. This happens a lot for those who are struggling with trauma. Because if we have experienced trauma, no one has ever taught us how to deal with trauma. The world at large doesn't know much about trauma and how to work with it. So what do a lot of us do who struggle with trauma? Is we began to use our own strategies. And sometimes we grab the local bottle or some pills or something else. Some of us eat our feelings. Some of us completely disassociate from the world and we kind of numb ourselves because that part of our brain is telling us, you've got to protect yourself. And so now you've got an individual who maybe meets the criteria of what we call post-traumatic stress syndrome. And they have now gathered, unfortunately, an addiction to go on top of that. Or maybe someone is severely anxious and they don't know what to do with all of these angst. And so they begin to pop in a Xanax to help reduce some of that. But then next thing you know, they're taking way too many Xanax. Or they go into the bottle to help calm some of the nerves. So the comorbidity or the dual diagnosis, that shows up a lot within the world of trauma and alcohol. Those are probably the two of the biggest overlap. There's a lot of overlap there, but those are the two areas that overlap more often than not, is the world of trauma and alcohol. All right, let's go ahead and go to the next slide. And this is where we're going to talk about different theoretical orientations and modalities. Those countless hours that we spend in school and those really nice, thick textbooks that cost us $400 are teaching us this. A lot of different theories and modalities. There are more than 100 plus theories and modalities. We are not the expert of all 100. More often than not, there's going to be an assignment probably around your junior year where you've learned a lot about all the different theories and they ask you pick one or a few and begin to kind of spell that out a little bit more. And that's where we develop our orientation or our modality. Basically what that is this is how we perceive the world of mental health. You guys have all heard the term worldview. We all have a worldview of how we look at the world around us, or politics and or anything else going on in the world around us. This is kind of like a worldview, but for mental health. This is how we view your mental health struggles. Most of us have maybe one or two different theoretical orientation modalities. I'm just going to cover 4 of the more common ones. There's a lot of them. Just because it's not up here doesn't mean it's bad, doesn't mean it's wrong. They're all good and beneficial in its own right. But these are the ones you're going to see a lot. Remember how I said alphabet soup? There's more. CBT, cognitive behavior therapy, probably one of the more common ones. There's a lot of research on CBT. The very essence of CBT is we believe there are 3 things going on for an individual at all times. You're always thinking about something or you're believing a story, which may or may not be accurate. We've got behaviors that are going on. Even you sitting there right now, you're engaged in behaviors. Obviously, I'm engaged in behaviors. And then we have this wonderful world, so complex and so complicated, the world of emotions. And so all 3 of those go hand in hand, and they directly influence each other. So in other words, the more I think about a particular story that I'm telling myself, the more likely I'm to operate on it. So let's say, for example, you see a friend at Walmart and you say, oh, hey, Susie. And Susie keeps walking along. What's the story you're going to tell yourself? Now, it depends. Some might think, I can't believe Susie would just ignore me like that. And then you begin to go into this spiral of things. Susie's mad at me. She didn't like the last phone call that we had. And I said something about her mama or whatever the case might be. And now Susie's mad at me. See, she's ignoring me. Now imagine how that's going to impact my behaviors. We run into each other in the milk aisle. Depends on how deep this story is. If I see her at the milk aisle and I'm really upset with her now, do you think I'm going to talk to her? If I do, I'm going to do maybe one of two things. I might tell Susie a piece of my mind, which may not go well. Or if you're like me, remember, I'm an avoider. I don't need milk at the moment right now. We're not that bad. We still have that much. I'm going to go get a new t-shirt. And I'm going to go to a totally different side of the store because now I'm trying to avoid her. Because of the story I told myself, which may or may not be accurate at all. So we've got the world of our thoughts, which directly impact our behaviors and what we do. And then, of course, those impact our emotions. What do you think I'm feeling the more I stew on Susie Q, who is ignoring me? I'm going to get more worked up. I'm going to get maybe more angry, maybe more anxious, maybe more depressed. And it's going to go on and go on. And it becomes very cyclical in nature. What I say is these often become self-fulfilling prophecies because if Susie Q was not mad at me and didn't hear me, do you think she's going to be mad at me whenever I give her a piece of my mind? Yeah, probably, right? So somehow, a lot of times this can become a self-fulfilling prophecy. So someone who works from a CBT modalities, we want to help you understand what is the story you're telling yourself. Is it accurate? Is it not? It probably more often than not is not, or it's definitely influenced by your relationships. Because remember, I'm an insecure person because of how my dad interacted and treated me. So I'm going to look at everything through the lens of insecurity. And so we, as CBT therapists, we want to make sure you understand your thoughts and the beliefs of what's going on there. If you're familiar with the Bible, Paul talks about it a lot. Philippians 4:8 Philippians chapter 4, verses 8 and 9. Really good. You read those two verses, you will understand CBT at a very high level. So that is the world of CBT. Want to help you understand your thoughts, understand your behaviors and what it is you are engaging in, why you're engaging in those. And we want to help you understand the world of emotions. Not to change an emotion, because remember, nowhere in the history of the world is anyone calmed down because they were told to calm down. Instead, to understand, this is why I'm getting very anxious right now. This is why I'm feeling really depressed. This is why I want to understand the world of emotion and learn to do some things to help settle it and cool it off a little bit. All right, so that's CBT. I talk a little bit more about that because that's one of the few modalities that I primarily practice from. The next is DBT. Love our alphabets. DBT is dialectical behavior therapy. This is for someone who has the symptom of dealing with some very strong emotions. If you are any Star Wars nerds in here, you say the Force is strong with that one. Some people, those emotions, they show up and they are very strong. For me, emotions generally show up. I'm like, what? There's an emotion? I don't know what you're talking about because I'm an avoider. Other people, not so much. And they feel things intently. And so DBT is really good to help manage some very, very, very intense emotions. So that's about DBT. A lot of focus is on calming coping strategies and trying to begin to look at the world slightly different. There's a lot of overlap, and a lot of these DBT is similar to CBT in some ways, but again, it's a totally separate orientation and modality. Family systems, because I'm a family guy, licensed marriage and family therapist. I primarily operate from this modality and sprinkle in a healthy dose of CBT. We believe that the individual, or we look at the individual from the context of their entire family relationship. So yes, I'm going to ask you, tell me about your mom. Tell me about your dad growing up. I want to know a little bit more about that. I want to know about the family relationships that you're currently in. What is that looking like? How about the relationships at work? What does that look like? How about your relationship with society at large. And we try to look at the individual from the context of their family relationships, because no matter how much we might think our relationships do not impact us, they do. I've got a client right now, he's got some trauma going on, and he's having a hard time working through some of his trauma because of whenever he goes home, his wife re-triggers a lot of things. Not necessarily because she's a bad person, because she is relating and interacting with her husband because of her own trauma. And well, you've got he who is traumatized, her who's traumatized. You put it together, it gets a little complex. And so again, that's why we like to look from a family systems perspective. So if the issue is relational at all, I would encourage to find a licensed marriage and family therapist, or at least someone who has some specialty in understanding relationships at large. That's a little bit about family systems. There's a lot of different types of system work underneath that. It could be internal family systems. There's some Gottman stuff. Sue Johnson does emotionally focused therapy. There's a lot of subsets when it comes to systems. But the idea of systems is it's like a lot of gears. You move the gear this way, and what happens to the next gear? It moves it this way. Then this impacts this, and this impacts this. It's all going to begin to impact each other. Family systems, we're looking at it from a big perspective, not just zooming in the one small area of life. Now, last area, again, just for sake of time, is EMDR. EMDR is, it's a little bit of talk therapy. This also requires a certain certification that you've got to do. The EMDR is a growing focus and modality on trauma. I talk about trauma because trauma is one area of mental health most people do not understand. If you say you're anxious, okay, I think most people understand your heart. Oops, sorry, I hit the mic. Your heart's probably racing a little fast. You're starting to feel a little jittery. Most people understand depression a little bit, really kind of sad, just in a little bit of a funk. Most people do not understand trauma at all. A little bit to understand about trauma is we've got to understand the brain. And so I'm going to tie this back into EMDR here in just a second. Whenever we experience any traumatic situation, it alters our brain functioning, whether we like it or not. Now, most of us, when we think of trauma, we think of the big T trauma. This is someone who was in military, in combat, or in the armed forces, or the local police force, or the firemen. They are experiencing traumas all the time. Nurses, they can experience trauma all the time. These are big T traumas. Maybe you're involved in a horrific car accident, big T traumas. Most have not experienced big T traumas very often. I would go so far as to suggest almost everybody in this room has experienced little T traumas. A little T trauma is basically defined as I have this expectation, this idea of the way something should work, and it doesn't happen, and it impacts me. Now, sometimes we can just let it roll off. I'm an avoider. I think most things roll off, but a lot of things impact me that I don't like to look at. So little T traumas can be something such as mom and dad were supposed to support and encourage me, but instead of offering a loving, nurturing environment, they were angry all the time, and they're harsh and critical. So I never experienced any big T traumas. Luckily, all my bones are intact. I've never had a surgery of any kind, except for an ingrown toenail. That was weird. But I've never experienced any big T traumas. But I've experienced a fair share of little T traumas, all of which have impacted me. And so what happens is when we experience a trauma, it is burned into the memory of our brain. Now, anything that looks like or sniffs or reminds us of that particular incident, we go right back into, because that memory was stored in that part of the brain. Has anybody seen Inside Out, either one or two, the new movie? Whoa, it is so good. It is so accurate in so many levels. Imagine one of those marbles. It's put in the part of your brain, which the sole purpose of that part of our brain is to protect us. And so it responds in one of three ways: fight, flight, or freeze. Freeze is like the deer in the headlights, like there's a car coming. I should probably move, but I can't. And then unfortunately some bad things happen. Or they fight, they get into fight, and that's where anger shows up. My dad primarily operated from fight. My mom primarily from flight. And she ran from things. My dad was probably a little bit of both. I found that I modeled it from my mom and dad. I was also angry for a long period of time and was an avoider at the same time. So I would do both. And so those memories, those traumatic situations are burned into that part of the brain. And so anything that looks like what I experienced before, I can't help but to respond from a place of fight, flight, or freeze, because that's where it is stored. So in order for us to work through trauma, we've got to literally move that marble to the other part of our brain where it begins to process it. So I personally am not certified in EMDR, but I saw this with an individual who was involved in a car accident in a really bad rainstorm. So you can imagine after that happened, they were deathly afraid to get in the car anytime it was rain. And so their heart would start racing. They would make up all sorts of excuses. I can't tell you how many days of work they missed because it was raining. And well, if you live in Florida, where I grew up, it rains every day. And so you can see where that could be life altering. If it's around here for last week, there is no rain except for today, it seems. And so it could be life altering. And so for her, it literally paralyzed her. And so she went through EMDR and it moved it from one part of the brain to the other part of the brain to where now the brain says, you're right, this is scary. But you've done it before. You've only been in one car accident. You've been driving for 20 years. You're going to be okay. But it is probably good that you relax a little bit, take a deep breath, and be aware. If someone just goes to her and said, suck it up, buttercup, what do you think she's going to do? She's going to get in the car because she's being forced to. She's going to grab that steering wheel, and I'm telling you, she's going to squeeze the living life out of that thing. And if you've ever gotten really worked up on something, what do? We go into tunnel vision. And everything, I don't know about you, but you can see where this is going. That's not good to have tunnel vision while you're driving, unless you're in a tunnel. And it just begins to crowd in, and she's so tense. What's likely to happen again? Self-fulfilling prophecy. So what EMDR does through a series of eye movement or desensitization, it begins to allow your brain to reprocess it. Sometimes bilateral stimulation, or you hold little weird things in your hand and it does some like vibrating things, and it helps your brain to literally move that marble, that memory, to the other part of your brain, which now allows you to reprocess it differently. And now, whenever that individual gets in the car, sure, they're going to feel anxious. Oh, of course. Can they pretend this never happened? No. But they will hopefully be able to overcome that a little bit better and better every time. So that is EMDR. Again, this is only a handful of them. There's a whole lot more where that came from and a whole lot more letters and initials. But that is it in a nutshell. So that is basically all I have prepared for today. I have some questions though. All right, so I'm going to look at the questions. Okay, so I've got two primary questions I'm going to look at. The first one here is, how do you know what type of therapist will be best for your needs? If you have trauma, family issues, addictions, or is it best to just start and get the right fit? When you call a practice, will they best guide you? Okay, there's a lot of questions in here, which is why I like it. Like I said, there's a lot of therapists. Within our practice alone, we have more than 100 therapists. Within One-Eighty, we pride ourselves in a sense to be able to see anybody with any walk of life, no matter what issue you've got going on. Between the 100 therapists and the 6 different offices we've got, we probably have someone who can help you. Now, will you always find a single therapist who can hit every single situation? Maybe not. Probably not. So in situations where it's very complex, like this mentioned, some trauma and family issues and addictions, you've got three really big things going on. That makes it very complex. It depends. If you're going in for individual therapy, let me go back to what we're trained in. One of my professors put it best. He said, we're kind of like a triage nurse. You've got a client who walks in and they have a lot of things going on. Maybe they got into a car accident, they're bleeding out, they got a broken arm, and they got a concussion. I'm not going to care a whole lot about the broken arm. The concussion is going to be a concern, but this client's bleeding out right now. This patient is bleeding out. What do you think I need to focus on? The one that's most serious, life-threatening. So part of that might need to be figured out either by you or when you get in to see a therapist. That therapist will help you kind of go from there. So in other words, I've seen some clients who came in to see me for couples work. And a big part of what they're working through is the area of substances. I don't know a whole lot about substances, definitely not my cup of tea. Luckily, I don't have a lot of experience with it, even from a family perspective. I understand it just enough to get me by, and sometimes to get me in trouble. So in that case, I recommended him to see a licensed clinical addiction specialist because he had a lot of addictions going on. And so what I did in that case was I focused on the family relational stuff, and he did some of his individual work on some addiction stuff. We signed a release so the two therapists can communicate and make sure we're coordinating care. So sometimes we might need a few different therapists. However, there are some who have an area of expertise in two areas. And so you might be able to find a unicorn who can work with, say, trauma within the family context, or who can work with trauma and addictions. Those two worlds overlap a lot. So more often than not, those two things are going to be able to be addressed by the same individual. So to find a right fit, there is no perfect answer to that because everyone is so unique. You can find a therapist literally anywhere. You can go to Psychology Today. That has a lot of different profiles for all the different areas and therapists. Again, the only way you're going to see it is their little bio and their picture. I strongly encourage, because finding a good therapist is like finding the best friend, so to speak, someone you can trust and bare your soul to. If you know someone who has seen a therapist, talk to them. What is it you like about your therapist? What do you don't like about your therapist? Find out. You may or may not be a good fit to work with that one, but maybe you can make a quick call and talk to that one and figure out what other types of referrals are out there. So I don't know if that gave you a non-answer to your question, but I tried with that one. Is it best to just start and get in? Sometimes it is. Sometimes the biggest hurdle of getting in to see a therapist is this 3-4 inches between your ears, or the large distance between your head and your heart. So sometimes just get in there. Sometimes that is the biggest step. I can't tell you how many times I've got a parent walking in with their kiddo and like, kid's not going to talk to you, but I didn't know what else to do. And the moment the mom leaves, I pull out a deck of cards. I start shuffling. They're like, what's going on? And we start playing cards and I get their whole life story. So sometimes people are pleasantly surprised. A deck of cards, you'll be surprised what that can tell you. So again, sometimes you just need to get in to see a therapist. I think that answers all of those questions. Next question. Do you personally see adolescents? You referred to the DSM. It might be helpful for folks to explain what the DSM is. Good. So personally, I can work with adolescents. Whenever I was in the church world before, it was within youth ministry. That's where my original passion for family came in, because, teenagers and kiddos, you can see where they're trained from, is at home, good, bad, or indifferent. I see my kids and they are a spitting image of me, whether I like it or don't like it. Sometimes they get a lot of the bad qualities I really wish they didn't see, and they've got it. So that's why I personally like to work with, even though I do have adolescents on my caseload, I like to see the family unit to help work through some of the family things that's going on, not just for the teenagers. So personally, I don't see a lot of individual adolescents. However, I can typically 13 and up. The DSM is, again, sorry, love our alphabet soup. DSM is the Diagnostic Statistical Manual. I didn't put a lot of focus on it because it's a purple book and it tells you all about the mental health diagnosis. In other words, I would never do this, but I could. The client could sit in front of me. I'll pull out the DSM as they're telling me their story. I'm listening for symptoms. That DSM tells me, oh, these symptoms fall underneath this diagnosis or this diagnosis or these diagnoses. And that's basically what the DSM is. It helps us to understand the symptoms and categorize it into different diagnoses. But again, most therapists, we don't put a lot of focus on diagnosis. We'll probably have one. We just don't often share that. So we do have the DSM. It's probably somewhere hidden in our bookshelves or in our desk, but there's typically not a lot of focus on that. So I think that is all the questions I've got. Thank you. I appreciate it. Thank you, guys.